So are chiropractors really trained to deliver stem cell treatments in their practice? The short answer is no. So I'm Dr. John Tait. I'm a non-surgical orthopedic doctor, and I specialize in regenerative medicine, orthobiologics. And some of the treatments we use under that umbrella in a practice like mine are stem cell treatment, are PRP treatments. And first of all, this is not a hit piece on chiropractors. I want to give a shout out to my colleague and friend here, Dr. Osborne, chiropractor down in Sugar Land, Texas. One of my early mentors in functional medicine, outstanding clinician, really helps people optimize their health and obviously figure out where things can be triggered in the body from pain. Like some people are really gluten sensitive, hence the title of his book. So, there's chiropractors out there that I think are just like super high standard guys like Dr. Osborne. There's two friends of mine that recently retired that I'm really disappointed out now with Dr. Ron and Dr. Lisa here in town, that we used to collaborate on a ton of cases where they were doing their thing, I would do my thing, and we get a ton of patients better, because there is a tissue issue sometimes that stops the patient from progressing. If you're doing manual therapies like chiropractic, if you're doing physical therapy, there's a point that we can turn the body around, and sometimes there's a point we can't because the actual tissue problem. If you have cartilage breaking down in your knee, you have a partial tendon tear, sometimes those things with enough time, space, and good hands-on treatment can heal, and other times they can't, which is where my chiropractic colleagues locally say, hey, can you take a look at this patient and see if we combine what you do with what I do, can this really get the patient better? So if we dig into the training and qualifications to do this stuff, first of all, we can kind of walk back through training of a doc like me and training of a chiropractor that is doing treatment in their office. So let's just start at the top. Chiropractors do 4 years of schooling, and I do 4 years of schooling as a medical physician, right? Medical school is 4 years, chiropractic school is 4 years. Then typically we go on to do an internship year. Then after that, we go on to do residency years. And in my case, I did 3 more years of training. And after that, I did 2 fellowships. So if you're counting up the years over here, that's a lot of years. Now, to be fair, chiropractic colleagues do go out and do residency training where they can do additional 2 or 3 years of training in a specialty like neurology or musculoskeletal sports medicine. So again, this isn't a hit piece on chiropractors by any means, but if we distill that all down, nothing in that training over here, chiropractically, gives them a license to inject patients. Okay, I'll repeat that again. Chiropractors do not have a license to inject patients. So then how can chiropractors be injecting people? So I'll give another tap and a shout out to a colleague of mine in Fort Lauderdale, Florida, Dr. Giuseppe Pays, who I did my residency with in that 3-year block, because he was a chiropractor that said, hey, I love all these tools I have. I'm treating patients every day in my practice, but there's some limits to what I can do here. So he actually went back to medical school after chiropractic school, after he was out in practice, and went back through similar residency training program to me and fellowship training afterwards in interventional pain management to be able to do these injection therapies, to kind of combine the best of both worlds there, with what he could do with his hands, what he could do with his diagnostic ability, and what he could do with interventions, whether it was hands or with needles. So that's the rare exception as a chiropractically trained physician, but obviously went back through medical school to be trained as a medical physician to be able to inject. But chiropractors do not have a license to inject. So then how do they inject people with stem cells in their practice? Well, what comes about in the process of practices doing this is they hire typically a nurse to do it. Sometimes it can be a physician trained like myself, and this is why I'm doing this piece today, for you to understand who's actually doing your treatment. So if you're getting treatment in an office like this, you have to understand who is the injector, right? Because the chiropractor may be able to set up the reason behind it, and look, there's a very good reason to do these things. They want to help with that gap where hands-on isn't working, all the other modalities we have isn't working, so now we have to maybe move into a cellular therapy like stem cell or PRP to help that tissue heal. So on the surface, there is absolutely nothing wrong with that. Then what they have to figure out is who can inject this patient. So again, I have seen and researched for a couple patients of mine in other states. Do they have somebody coming into this office with the credentials and the training to be able to do those type of treatments. And so if we break down the training like I did for me, we did the 4 years of medical school, we did the year of internship, we did 3 more years of a residency specialty training, in my case physiatry with this non-surgical orthopedics, and then I did 2 fellowships. So 10 years of school and training, and over that time, thousands of injections performed under supervision of very skilled attending physicians. And then attach that to another now 14 years out in practice, where I probably averaged more than 6, 7, sometimes 800 injections a year. And you can see the cumulative practice and experience that comes with that. So when we flip that over to folks that are coming in and really hired to come into an office, we really have to examine their training. Have they put in all those years under supervision of very skilled attending physicians that teach them the proper technique? There's a question mark there. If we look a little bit further, do they have a license to inject? Well, they have to. So oftentimes in those practices, it may not be a physician orthopedically trained like me or sports medicine trained like me. It could be a nurse or a nurse practitioner. And again, there's nothing wrong with nurses doing injections, nurse practitioners doing injections, but if we look at the cumulative amount of specialty training they have to inject somebody orthopedically, it is very different than giving somebody a B12 shot or a vaccine or something like that, okay? Because if we look at the scope of nurses training or even a nurse practitioner's training, depending on what specialty they're in, they're not going to get a volume and repetition of injection experience equal to an orthopedic surgeon, a non-surgical orthopedic doc like me, a family medicine or internal medicine doc that's specializing in sports medicine. You're going to do hundreds upon thousands of injections under supervision over the course of your training. What that means is you should have a way more skilled person than delivering that needle into the joint, because the precision and placement of this treatment matters, right? It's not a spray and pray that it works. You have to really place this stuff at the tissue sites where the problem is. And so we'll get to that next piece then. So if we evaluate the skill and the training of that individual, yes, they could have a license to inject you, but do they have years of training, thousands of injections under their belt to know you can have somebody put that needle where it needs to go? So that's piece 1. Step 2, how are they guiding that needle to the destination? In my practice, everything is guided by ultrasound, where I can put a probe on an individual and I can see my needle underneath that going to my target tissue. And that really is the standard. Some physicians use X-ray, or it's called fluoroscopy, to do certain procedures, and that's fair too. But it gives us eyes on the target. We're able to see exactly where that needle path is at all times to guide it to the destination where it needs to go. So if the person, and as you're examining these offices doing injections, if they are not using guided treatment, if they are not using ultrasound or fluoroscopy to do your treatment, then you're already getting an inferior treatment, right? Somebody says, oh, I can inject this joint without that. There was a good study published way more than a decade ago showing experienced docs, people like me, thousands of injections under our belt. If we try to aim a needle into a knee joint, which is a very common joint to inject, in the study they showed that experienced injectors could be missing that joint 1 out of 2 times, meaning the stuff we're trying to inject isn't being delivered into the target area of the joint or the tissue. So now if you're getting these treatments and you're paying out of pocket for these treatments, and they're not, mortgage your house expensive, but you got to pay some money to get these things done, and now the person doesn't have the training, they're not using the guidance to inject you, okay? How do you know that you're even getting the stuff that you're paying for into the tissue where you need it? Because there's some limits to what those cells can do. They can't drive through walls of tissue planes sometimes. They get stuck. Yes, we can release growth factors, what we call exosomes, from these cells and other proteins and cytokines that help in this healing mechanism, but you really got to get these cells to the doorstep, more importantly, right on the target of that tissue, whether it's cartilage breaking down in the knee, whether it's a partial tendon tear in the rotator cuff. I want to see my needle going right to that site. I had a woman yesterday, she's a skilled injector in a different region of medicine with aesthetics, right? And we were watching during her procedure, and she was, because she's super interested in it, we're watching on the ultrasound screen as I deliver the treatment, those cells kind of percolating along that tissue site that we want to hit. So we know, hey, we got it right where it needs to go. We know as this patient heals forward over the next 6 to 8 to 12 weeks, if she gets better, we know why. If she doesn't get better, then we got to pause and think about, hey, do we need a different type of treatment here, a combination therapy of some type to get that issue better. But if you don't even know if it's getting to the tissue site and you don't get better from the injection, it may not be the fault of what was injected into you. It may just be that it didn't reach the target, okay? So now if we go on to why did these pop up everywhere? It makes sense. I mean, if we kind of look behind the scenes at what these treatments can cost if you're paying out of pocket versus other service lines that may happen in office, it's not hard to make the leap as to why this became more prevalent and why companies started bringing different products into these offices and saying, hey, you can take, this product here in this, pamphlet and just use this and inject this into patients, and it'll give them these growth factors and other things to stimulate healing. Well, so there was a time and a place where a lot of those tissue growth factors and birth tissue derived, and I want to make the separation here, okay? Back in the old days, 1980s, Reagan administration, they were talking about embryo research. They're talking about using some of these embryos to study stem cells, study the ability of stem cells to treat certain things. That is not what clinicians, practitioners, physicians like me are using nowadays. We're using cells from the patient, what we call autologous. It means the cells are derived from you. And we can take them out of your bloodstream. We can take these out of your fat tissue. We can take these out of your bone marrow, and we can get different types of healing growth factors or cells to stimulate healing of these tissues. So again, asking more questions about that clinic where you're planning to get your treatment. Are they using those type of treatments? Are they going to take your cells and use them? Because that is, according to the letter of the regulatory policy of the FDA, what we're supposed to be using. All of these other products that are being positioned and sold to practices don't really fit the letter of the law anymore in 2024. Meaning the government has been regulating a lot of these for a long time, so the ways you can get access to these are through very regulated pathways where people are studying new, we'll call it drug development, in this case it's orthobiologic development, and you have to have things like INDs, investigational new device numbers, or you got to have IDEs, which are investigational device exemptions, to be using some of this stuff in a clinical setting, but also a research setting. So the clinicians that are using those things are developing treatment pathways and doing the research on it to see, can those things work pretty well? Because I've done other content on that, and I think the future is really bright for using what otherwise would be medical trash after a very common procedure, delivering a baby, and all those tissues with all those viable cells and growth factors could be utilized for good to help millions of people. And so I think there's going to be a pathway, obviously, that develops to develop more of that treatment under a very regulated umbrella to have access to that. In the current day, right, some of those clinics are just using those growth factor products, the very things that the government says you probably shouldn't be using as much of those things unless you have some kind of connection to an institution doing research. So, there's some certain trip points that as you examine what's going on in those clinics, you really need to understand those type of treatments. And the final thing I'll get back to is what I call the 3 T's. And I've done a couple other pieces on this, but I walked through a couple of them today. We talked about the training of the individual. We talked about the technology to deliver the treatment, like ultrasound or fluoroscopy, to guide that injection precisely to the target. And there's also a whole other scope of technology that happens behind the doors once your cells are taken from you into a lab. And if they're not processing your cells again in a lab, then you got to have some question marks around what is actually happening, with those cells that were taken from you, and what kind of equipment are they using to process those cells, and what kind of end product are you then getting from those cells to be injected back into you. So you can start to see all these checkpoints in your treatment as you evaluate who's doing it, how they're doing it, how they're delivering it back to you, and understanding what you're actually getting put back into you is going to influence the likelihood of success with these treatments. Because, look, this is all I've done in my practice for over a decade now, and done really well. These have high potential to help people for the right situation. So I'll get to my final point. There's a lot of people that are injected that have no chance of improving with these treatments. And I just bristle at that because when patients come in and they've failed treatment elsewhere, and they've paid a lot of money for that treatment. And now they're facing the reality that they got an inferior treatment done by somebody that's probably underskilled, or the quality of the product they got was not really a quality product to change this tissue. The bigger issue is whether or not that had any chance of helping the patient in the first place. Because every week in my practice, I have the hard conversation with people that have waited too long, and maybe 10 years ago their knee started hurting. 5 years ago it was hurting more. The last 2 years more. And the last year really miserable by the time they limp into my office. And they're at the point of almost no return, where the knee is degraded so much that we might be able to buy some time with some pain relief if that's what they're looking for out of these treatments. Because again, they can relieve pain powerfully for the right patient in the right case. And it's way healthier and way better, in my opinion, than corticosteroids that can relieve pain but degrade the knee. But at that point, for some people, we're just buying time. 2 years from now, 3 years from now, 5 years from now, however long that treatment may last for them, they're going to be getting a replacement. And that's where a doc like me has to sit with you, the patient, weigh all the options. Is surgical option the best option for you? Is a stem cell treatment or a platelet treatment even got a possibility to help? And if so, based on all of my decade plus of doing this in my practice and experience and repetition collecting that data on patients like you with similar issues, what's the likelihood of success, right? I can actually give you some numbers from my own data to say, this is the likelihood of success for a patient with this issue, this grade of arthritis, or this type of ligament tendon injury. Now, I can give you the data, but there's not certainty in that. So none of these treatments, I'll kind of end and wrap it up with this. None of these treatments are guaranteed to work every time. There's very few things empirically in medicine that work every time. And lethal injection doesn't even work every time, right? So we have to look at, one, is this the right thing to do? Two, what is the likelihood of success to get you the outcome you need to benefit the problem you have? And how long is that likely to help you before we have to consider other options? So my job as a non-surgical orthopedic doc, even though my bias is to do non-surgical things by way of all that training, I still have to tell you, the patient, when the time and the place has come, that, look, we either got to stop doing this because your quality of life is hanging in the balance and you're not getting the outcome you need, or when I see somebody straight away at the beginning that has lost the ability to bend over and tie their shoes because their hip is so bad, right? And they want that motion back, the ability to squat down and rotate their hip and rotate on their hip to play golf. And some other clinic may say, yeah, we can totally fix that and give all your range of motion back, and it's going to be just like your other side. And that is 100% bunk, false. When somebody's got to that point, it is very, very slim odds that they're going to restore that joint to the level of range of motion and function they have in the non-affected side or the less affected side. So these are all these things I'm weighing with the patient, right? The age of the patient, how severe the problem is, how chronic it's been, what other treatments they've done. And look, do we have a viable option, like a guy this week, to say, look, just go get the hip replaced, and in 2 to 3 months, it's probably the same recovery time from what I'm going to do. You could have a brand new hip and be back on the golf course, pickleball court, whatever you're doing. So it comes down to that specific conversation. You have to have a very skilled practitioner with that experience, with that data, with a practice that entirely focuses on this type of treatment, not dabbling in it, focuses on this, specializes in it, refines every week how they do this to give you an honest answer about, can this stuff even help you? So the takeaway point is, you need to be very selective, and you need to work through all of that criteria I mentioned to make sure you're getting the best treatment you possibly can. So that's my semi-rant for today, but it's something that people just have to know, and you have to share this with a friend. If anybody around you is looking for these type of treatments, certainly I'd love to see in my practice. So if I can help you in any way, please subscribe to the channel where I can teach you what we're doing with these type of treatments. Share this with a friend. And if you're local or not even local, we see people from all over the U.S. in my clinic. There's always a link in the section below the video to link over to my practice. Talk to somebody on my team who can walk you through all those steps I just mentioned to see, do you have a good shot at success with these type of treatments?